for
A very good afternoon, ladies and gentlemen, colleagues. You're all welcome to this week's echo session. We are glad to have you on this call today from wherever you are. You're welcome. Just to do a quick introduction, this month's or this week's session is about management of sepsis and septic shock in the emergency department. And we do have a panel of experts that will be sharing their experience, sharing the recommended care. And I believe all of us on call will pick a thing or two from this session. You're welcome, and we'll do a quick round of introductions, starting from my right. Yes, you're welcome, Miss Olive.
Good afternoon, everyone. My name is Olive Davidio, and I'm an ICU nurse at Rosewell Specialist Hospital. Privileged to be here.
Okay, you're welcome, Olive. Next to Olive.
Yes, good afternoon, good evening, everyone. I'm called Nambago Simon, and I'm a resident of internal medicine year 1. I'm happy to be here.
You're welcome, Dr. Simon. Then to my left, next to me.
Good afternoon. My name is Erasmus Okeno. I'm a critical care physician. I work with Macquarie University as well as TMR International Hospital. Thank you.
Thank you, Dr. Erasmus. We're glad to have you here. And next to Dr. Erasmus.
Greetings, everyone. I'm Dr. Shevin Jacob. I'm an infectious disease physician. I'm based here in Uganda, but I'm back at the Liverpool School of Tropical Medicine and a co-founder of the NGO Walloon.
You're welcome, Dr. Shevin. Glad to have you here. And lastly, next to Dr. Shevin.
Good afternoon, everyone. My name is Okrot Andrew. I'm an EMT by profession from the Ministry of Health, CAD, and also Zambia Hospital Training School. Thank you.
You're welcome, Andrew. And lastly, myself, I am Anna Kaguna. I'm an emergency physician currently working under Mulago National Referral Hospital, and I'll be your moderator for this session today. You're all welcome. And just to get a quick echo of what everyone else, in case you're logged in, I see we have 134 participants logged in already. You're welcome. We just want to see and to hear your expectations for this session today. Maybe I'll pick 2 people, if you're able to unmute and tell us what do you expect to learn from today's session, or what would you want our panelists to teach you today. Just 2 people. You can type in the chat. You can let us know directly over the next 1 minute. If you're able to raise your hand up, we shall unmute and you'll tell us what you expect. Okay, anybody out there would love to share with us what the expectations of this session are? How about Nicola? Okay, we have is that Tumanye Simon? You can hear from Tumanye Simon and Bale Simon Peter. First, Tumanye.
Thank you so much. My name is Tumanye Samson. Yes, my expectation for today is emergency care and management of a patient who has septic shock. How do we resuscitate such a person so that we save their life?
Okay,
yes.
Thank you, Mr. Tumanye. I believe by the end of this session, you will have your expectations met. I hope so. And then just one more from Bale.
Yes, good evening. I'm Bale Simon Peter. My expectations about the recap, or if it has been shared before, about the nomenclature of sepsis and the SOFA score and the Q SOFA and how diagnosis of sepsis is reached, then management of sepsis and the definition and management of septic shock.
Okay. Thank you so much, Bale. And I've seen a few people in the chat write the expectations. Some want to know the protocols, some want to know the SARS criteria, septic shock, the difference between the two. I believe by the end of the session, we have a wonderful panel of experts. We shall have picked something, and I hope we meet your expectations. Just a reintroduction. Today's session is going to be a little bit different from what we do usually. We shall have our panelists discuss, and we shall not have a lot of the presentation that we've been doing. We shall have a more of a table discussion. And I hope we can learn a bit more from this session today. To delve into this session, we're going to start with Dr. Shevin. And as earlier said, he's an infectious disease specialist. He will be giving us a quick run through the epidemiology of sepsis globally and in Uganda specifically. Let's all welcome Dr. Shevin. You're welcome.
Thank you, Dr. Anna. So someone will control. Perfect. Okay, so yeah, just I'm going to provide maybe just a brief global context before we talk about our patient here in Uganda. You can advance the slide. And just to make sure, I know all of us know what sepsis is, but to be sure that we're speaking from the same book, the definition of sepsis is here. It's a medical emergency that is life-threatening organ dysfunction due to a dysregulated host response to an infection. And the infections can be any of the classes of infections, so anywhere from bacteria to parasites and fungi and viruses can all cause sepsis. The other part is who is affected by sepsis. Oftentimes people think about sepsis just in the peripartum area period or in neonates, but we must remember that sepsis can occur across the life journey, especially among vulnerable populations, including those who are immune compromised and the elderly. So we also should remind ourselves that sepsis globally is very important. And in fact, just last week, there has been an update that was published on the global burden of sepsis. And that was updated on estimates from 2021. As you can see here, and for those of you who are aware of the previous estimates, the global estimates have increased to over 21 million deaths per year. And 85% of these deaths occur in low and middle income countries. And you can see on this map that shows the mortality of sepsis globally in those areas that are dark red and orange in sub-Saharan Africa. That's where the greatest proportion of mortality is seen. And it's in this context that the WHO back in 2017 at their World Health Assembly passed a resolution making sepsis a global health priority. And so the goal is to improve the prevention, the diagnosis, and the management of sepsis. And this was ratified by all 194 UN member states at the time. And since then, I'll say, admittedly, there's been a slow uptake in terms of the global kind of advocacy and addressing all of what was meant to be done during the resolution. But there has been a revival of this resolution and ongoing support and commitment from the WHO. And this is just a screen grab of Dr. Tedros, the Director General of WHO, talking about the importance of sepsis in September's World Sepsis Day video address. So before we kind of just go into the patient case, I like to think about sepsis using this framework, the sepsis patient care continuum, and it really allows me to think about how we manage patients with sepsis from the perspective of the patient. So, whether we're here in Kampala or in Western or Northern Uganda, wherever we are, patients have to first know that they're sick and be heading from their homes to some definitive healthcare facility to receive the advanced level care that's required for sepsis. But as we all know, there can be many gaps and barriers along the way. And then when the patient arrives at the health facility, then there's also potential delays in early identification and the diagnosis and the effective management. So, thinking about that framework from home to health facility and back to home allows us to now think along that continuum about certain areas, knowledge areas. You could just specifically thinking about early recognition and triage, diagnosis, early appropriate treatment, monitoring and ongoing treatment. And when we go beyond the emergency department and when the patient recovers, recovery and rehabilitation. So we'll come back to this later, and back to you for the case.
Okay, thank you, Dr. Shevin. He has given us a quick overview of what's happening in the world, what is written, what's out there. And now we want to come back home and see one of the patients that was managed for sepsis. And Dr. Simon will take us through the case that he managed. You're welcome, Dr. Simon.
Thank you so much, Dr. Anna. So I'm going to present the case, the patient managed in clinical emergency in Malabo. So this was a 37-year-old male with no known chronic illnesses, a self-referral from a peripheral clinic due to worsening clinical state. So he presented with high-grade intermittent fevers for 1 day, associated with difficulty in breathing, and then fatigability, generalized body weakness, and joint pains. And over 3 days, when the illness was evolving, he had altered mental state, which worsened over time. And at the time of admission, he was brought in semi-conscious. There was no history of headache, no chest pain, no cough, no lower swelling, no seizures, and there was no history of trauma which was reported. So we did a primary survey, and the airway, he had noisy breathing with copious oral secretions. The breathing was tachypneic at 46 breaths per minute, with a saturation of oxygen of 79% and 5 liters per minute by bronchs. Had symmetrical chest expansion with bilateral diffuse palpitations and transient sounds. The saturation had cold clammy peripheries with a capillary fill time of 4 seconds and the pulse rate of 127 beats per minute. It was small volume, regular, and had a blood pressure of 116 over 84 millimeters of mercury. In the disabilities, we looked at the DCS, where he had an IOPN of 2, verbal 2, motor of 5, that's a total of 9 out of 15. People who were equal and reactive to light, no focal neurological deficits. Random blood sugar was 8 millimoles per liter, and we did not observe any convulsions. In the exposure, the patient was favorable to touch, no various injuries, no petechiae or ephimosis, had a urine bag in situ with black urine, and the volume was 100 mils. So maybe something to think about. What are the imminent emergencies in this patient?
So we're going to run a poll question. We're going to see it running on your screens. So pick the best answer, and then we shall come back shortly to continue with the case presentation. So the questions are: what are the imminent emergencies in this patient? Think through it. I believe many of us who have been around this area, we've learned how to screen for emergencies. So what do you think was an emergent thing in this patient? Was it the airway? Was it threatened airway? Was it hypoxia? Was it any of the questions, any of the choices you make? We shall be able to see. So this poll is going to run for over the next 1 minute. Okay. Okay, the next 2 seconds, we are ending this poll. I see only 120 of us have given us their responses, and we are 216. Half of us have given the response. So we are bringing this poll to one end. We shall be able to discuss the answers to these 4 questions. So let's have Dr. Simon continue with the presentation.
So yes, the emergencies which we saw these patients. Yeah, starting with the airway, the airway was at risk. As you heard, we had noisy breathing, the copious oral secretions. So there was a risk of aspiration given the low BCS in this patient. Then the breathing, because the priority was hypoxia, there was respiratory distress. So the findings we saw the respiratory rate of 46 breaths per minute, the bad breathing, it's equal to 79% despite being on oxygen. There was a risk of respiratory failure, then also a risk of cardiac arrest. In the saturation, there was an inadequate tissue perfusion, as evidenced by the cold clammy peripheries, capillary fill time of 4 seconds, a very high pulse of 127 beats per minute, which was a small volume and regular. So there was a risk of multiple organ failure because of those findings. Then in the disability, at altered levels of consciousness, and as you can see, remember the GCS was 9 out of 15. So because of the altered levels of consciousness, the air was at risk. There was risk of aspiration.
Okay, thank you, Dr. Simon. Now, after showing us the risks in this patient, what do you think are the emergent management priorities for this patient? You're going to have a poll question run. Let's have this run over the next 1 minute. Let's make this fast. I can see no one has yet responded. What are the emergency management priorities for this patient? Okay, we are 30 seconds into our poll. Yes, keep those answers coming in. Okay, we are closing the poll in the next 5 seconds. Let's keep the answers coming in. Okay, so we are ending the poll. Half of the congregation has answered, so we shall end this poll and let Dr. Simon continue and tell us what was done to this patient in the emergency department.
So we intervened based on the findings which we saw in this patient. So for the airway, the patient was positioned, the recumbent position, suctioning was done, and an oropharyngeal air was inserted and, in preparation for intubation. Then for the breathing, we had to put the patient on non-rebreather mask at 15 liters per minute, and then bag valve mask ventilation was initiated with oxygen at 15 liters per minute. Then for the saturation, given the cold extremities, findings were pointing to shock, we had to put 2 large bowel cannulae, and we had to run Winger's lactate at 30 mL per kg over 3 hours, and 1 hour was given in the first 1 hour. IV noradrenaline was also started, an infusion at 0.05 micrograms per kg per minute. Then, based on the reduced level of consciousness, we had to position the patient in the left lateral position, and then also we had to insert an IV tube to ensure they don't aspirate. So these are some of the interventions we did, and we had started the stabilization process for the patient. So after stabilizing the patient, We now have to start our secondary survey, which starts with the sample history. Sample is just an acronym with S, meaning signs and symptoms. So this is a 7-year-old female brought in with a severe fever, that's with generalized body weakness, joint pains, altered mentation that worsened over time, and then developed PID. A stands for allergies. There were no known food or drug allergies. M stands for medications, and the patient was not on any known chronic medication. This stands for past medical history. This is a patient who was treated in the peripheral clinic for febrile illness and unknown medication. Then L stands for last oral intake. So the patient had last oral intake 24 hours before the presentation. Then E stands for events leading up to the presentation. So the patient first had a febrile illness for a week, then developed impaired level of consciousness 3 days before presentation, and on the presentation had DIP and hybrid fevers. So we had to do a complete head to toe examination, complete the secondary survey, and the general exam. This was a very sick-looking patient, no obvious respiratory distress. He was febrile. We were not able to take the temperature because we couldn't access at that time. The CNS, he had a DCS of 9 out of 15. The stress testing, because after putting the patient on non-rhythmic at inside per minute, the respiratory rate dropped to 20 breaths per minute. But however, at first it was 46 breaths per minute. And he had bilateral diaphragmatic crackles. CVS had cold clammy peripheries with a capillary time of 4 seconds. The pulse was small volume and it was high at 127. The important negatives: patient was not pale, was not jaundiced, was well nourished, had no petechiae, no ecchymosis, and we didn't see any wounds. Had a soft neck, because we can rapid to light. Had a negative hand sign, had no focal polypsis, the epic was not raised, had no mouth sounds, and the abdomen was also unremarkable. So based on the findings, we came up with a list of differentials. We thought of severe malaria in view of the high-grade intermittent fevers, the low level of consciousnness, and then also given that we are in a setting where malaria is endemic in Uganda, so we thought of severe malaria at first, possibly cerebral malaria. Then the second differential was meningoencephalitis in view of the low level of consciousness and the fevers. And then also the third differential was septic shock. As you can see, the features of sepsis, the cold extremities, the very fast pulse rate. If you try to calculate this shock index, it is above 1. So we thought of septic shock. And then we also thought of a pulmonary embolism, because as you can notice, the difficulty in breathing just came in one day. It didn't have difficulty in breathing, it was just a sudden onset development. So it made us think of pulmonary embolism, difficulty in breathing, and then needing very high oxygen, having very high oxygen requirements. Then also we thought of a possible aspiration, pneumonia in view of the bilateral diffuse crackles, very high oxygen requirements, and the low BCS. And as you heard, he had very copious oral secretions. So it made us think of the possibility of aspiration pneumonia. So maybe there's this question: what are the essential bedside investigations for this patient?
Okay, so thank you, Dr. Simon. And the team, you've seen how our patient has progressed, and I would love us to launch a poll over the next 1 minute. What essential investigations would you do for this patient? We are 300 people on the call. So the moment we reach half of this, we'll end the call. What would you consider most important in the emergency department? Suppose you had this patient before you and they've progressed the way they've been presented. What would be your priority investigations for them? Okay, can see 16 people have so far attempted. keep the answers coming in. Like I said earlier, we're going to have these questions discussed, and we shall see where our thought process were lying and what we can improve. Okay. We do have 40% representation. The moment we reach 50%, we shall bring this poll to a close. Okay, in the next, so we end the poll. We have 50% representation, so we are going to end this poll and let Dr. Simon conclude this case. Dr. Simon?
So we did some investigations. Of course, we didn't investigate as much as we wanted because we are in a resource-limited setting. So we were able to do a blood slide for malaria, which showed plus malaria paradise per hyper field. And with the full blood count, and what was remarkable about the full blood count was a neutrophilic leukocytosis with a NOMHB, normal platelet count. And we were able to do a point of care ultrasound, which showed good cardiac contractility with an inferior vena cava, which was well distended. And there was no fluid around the pericardium, no right ventricular dilatation, which was noted, and left ventricle appeared normal. So we continue to support this patient. We continue to do suction as necessary to keep the air patent. We gave oxygen, 5 liters per minute by nasal prongs. IV paracetamol was initiated for pain management and also management of the fevers. We continue fluids, that was sodium lactate. That means per kg over 3 hours while monitoring the urine output. We positioned the patient, propped up the bed, then each tube was inserted, then urinary catheter was inserted. So we're not able to do the weight of the patient, but we estimated the patient to have a weight of around 65. So we gave them IV artesunate at 2.4 milligrams per kg. That was around 156 milligrams. That's 0, 12, and 24 hours. We started a broad spectrum antibiotic, IV piperacillin, tazobactam, that is PISA, 4.5 grams 8 hourly. And then we had to maintain the patient on a vasopressor, IV noradrenaline infusion at 0.05 micrograms per kg. So the patient had a progression, and he was in the emergency department for about 3 hours while waiting for ICU space. As you can see, he was a candidate for ICU, given the findings which we had. So while we were waiting for ICU space, around 30 minutes before transfer, the patient had a cardiac arrest, and the CPR was done, and we had a return of spontaneous saturation after 8 minutes. So we transferred the patient to ICU for post-cessation care. So what are the components of post-cardiac arrest care? You'll help us to answer that.
Okay, thank you so much, Dr. Simon, and for the excellent management of this patient. Now, over to the team on the call. Our patient arrested, and would love to know from you. We're going Okay, just attempt the poll that is before you. Okay, it's been brought to an end. Sorry about that. Okay, so Dr. Simon, let's end this presentation. Over to you.
Yeah, so of course we had to continue to follow up the patient. Upon reaching the ICU, the patient sustained another arrest, and CPR was done, but it was futile. May his soul rest in peace. Thank you so much.
Okay, thank you so much, Dr. Simon. Before we go into the next session, which is going to be into pre-hospital care, there are a few concerns that we do have in the chat for this particular case presentation. directly to you, Dr. Simon. I think I'll pick only two questions. The first question is, was this patient dehydrated? Because I think there is a concern in gave fluids. Was the patient dehydrated? Were there clinical signs of dehydration in this patient? And then two, I noticed a number of people were concerned over your fluid choice. Why did you give Ringer's lactate over normal saline? Could you attempt to that? If not, our expert will give us the answers. Just with your thought process.
So
The first question was the patient dehydrated? Why did you give fluids to this patient? And then two, why did you choose Ringer's lactate over normal saline? I'm giving you 1 minute to just attempt.
thank you so much, Dr. Anna. There's someone asked whether the patient was dehydrated and why you gave fluids. Yes, if you look at this patient, they had the fast pulse, they had cold clammy peripheries. Those are features of hypoperfusion of tissues. And that's what made us think that this patient needs IV fluids. And then someone asked the question, why do we choose sodium lactate? Ringer's lactate.
Ringer's
Why do we
lactate
choose
over?
Ringer's lactate over normal saline?
Yes.
So when you're resuscitating patients, we prefer to use crystaloids, and most especially we prefer to use Ringer's lactate over normal saline because we don't know their acid-base status, and most of them come when their acid-base status is really like abnormal. So if you give normal saline, you are going to increase their chloride ions, and then you give them what they call hyperchloremic metabolic acidosis. That's why we prefer to use Ringer's lactate when you're resuscitating such patients.
Okay, thank you so much, Dr. Simon. I hope that was very helpful. If it didn't click very well, we do have personnel that have worked with these patients all the time, so they'll give us a good experience on that. Okay, so the next session, we're going to welcome our pre-hospital team. He had introduced himself, but just for the team that were not on when he had introduced himself, we do have Mr. Andrew Okuro. He's an emergency medicine technician who is going to take us through how would we approach care transport of a patient that is suspected or has been diagnosed with sepsis. Over to you, Andrew. You're welcome.
Thank you so much, moderator and the previous speakers and the listeners online. Thank you so much for coming in to join us. Basically, I've been introduced and I'm going to talk through the hospital care. Again, in the beginning, Dr. Jacob introduced this session and discussed about the global aspect of sepsis. And in his presentation, he basically shared some picture, which I'm sure most of you saw, about the continuum of sepsis. And in that picture, there was an aspect of a patient moving from home to the hospital and back home. So, and that directly brings me to the picture. The EMS is the one that is responsible for that movement from home to hospital and maybe back home. Yeah, so in EMS, basically, our responsibility is to ensure that the patient is cared for. Okay, thank you. So from that picture, if we can look at that picture, that continuum, there's an aspect of moving from home to hospital and onward. So the EMS, basically, we will ensure we support in the care and moving patients from one area to another, especially and in referral, during referrals. So that's another, it's also part of care, moving a patient from one facility to another. Now, to this patient that we've been having now, this was a patient that was moved from a lower level facility to a higher level facility. And for you to be able to move this patient safely, you have to prepare about 5 aspects to safely transfer this patient. One is the staffing. Now, the staffing here is the EMS team. Before this patient is moved, the patient has to be taken care of and to be resuscitated first at the scene, but also the resuscitation has to continue en route. So this therefore means you need to prepare a staffing at the level that can be able to support this care. And now this is a very critical patient who is a red patient. So you need to have a team, if it's possible, if it's necessary, to have even at the level of an anesthesiologist on team or an emergency physician for this patient, then you can have it. Because EMS, you have a lot of professionals that can work in the EMS. And on the staffing as well, it's also important to consider the aspect of the relatives of the patients. Most times, they are not staff, but they can support the staff in giving care, especially in providing some information, information about the patient, but also giving reassurance to the patient. So when the patient is being moved, the aspect of the attendance is also very key. And most especially when you're dealing with pediatric, that is when you really have to consider that aspect of, as you move them, the relatives as well play a key role. Then the other thing is about this patient is, the patient has to be prepared. How do you prepare this patient? First, we need to let them know where they are going to move. They have to consent to this movement. We have heard of cases where patients are moved to certain facilities, and when patients reach the facility, they refuse even to enter the facility. Why? Because perhaps they have not been prepared, and they have a right to deny care. So this as well can compromise the outcome of this patient. So it's very important to prepare the patient adequately, of course, including their relatives, by seeking their consent to the care. And then also, it's very important to prepare the equipment and the necessary medications that we are going to have for this patient. Of course, an ambulance is a very small unit that can accommodate a few equipment, including the people that can give the care, but you have to plan and prepare for the worst. So in this case, this is a sepsis patient, and in our differential diagnosis, I'm assuming this patient is picked from a lower level facility, whereby you might have, a lot might have not been done to this patient. For example, the labs, what, and so on. So you're just surviving on the differentials. And in this case, the previous presenter had given us issues with pneumonia, sepsis, etc. So when you're preparing to transfer this patient, you have to prepare beyond. You have to prepare really a lot. And also the other aspect about the preparation that we most times don't give much attention in the EMS is the hygiene of the ambulances. And recently, I had a visit in one of the about 2 regions, whereby we're doing some small supervision, and one of the things that we saw in the ambulances was the humidifiers. For example, they had the water that they usually fill in to when they're giving patients oxygen, and you find they are very dirty with some algae already lit. So in the preparation of the patient, it's very important to also consider the aspect of hygiene, the equipment. And then again, given the condition of this patient, this is a very critical patient. Now, the severity of the patient, however, is something that will determine what mode of transportation you're going to use. Of course, this is going to be a Type C ambulance. So you need to use a Type C ambulance, but also in a Type C ambulance, you also have to consider an aspect of other aids, for example, stretchers or wheelchairs, because you might reach in the facility and this patient this is a very critical patient that will not have to just walk. So make sure that your stretcher is you can offload it and roll the patient, or you can have a wheelchair on board, or in which at the receiving facility, make sure that you have modalities for moving the patients from the parking lot up to the internal facility where the patient is going to be. And then lastly, of course, this is something that I can't emphasize further. We all know in the care of patients and clinical care, documentation is very important. So whatever is done en route, again, I emphasize, care is given from the scene and en route. So that all has to be documented and handed over for the continuity of care, the next receiving team. And this handover, usually, we use that a simple acronym, which is on the extreme right, left, right. In black. So in that I will not spend a lot of time in it, but basically that is a structure that guides us in handing over the patient. Identification, basically, I need to know whom have you been transporting, but also who are you transporting the patient. So that means the receiving facility has to know who you are, what kind of patient you brought in, but also when you're handing over, you need to make sure that you identify who is receiving this kind of patient or who might hand over the patient to. Then the situation, this is what the patient is having, what state the patient is in, what things you observed as you're coming en route, and the background is what could have led to this circumstance. For example, if you have that information, and largely some of this information you get them from the attendants if you've picked the patient from home. But this patient in this case was picked from a lower level facility. So the background you will have got it from that receiving facility, and then you capture it as well. And then lastly but not least, en route, as you move with this patient, what did you do for the patient? Did you give some fluids? Did you do some resuscitation and so on? That as well has to be documented. For example, this is a patient that had a compromised air already. We saw the secretion. So if I suction en route, that has to be documented. How many times did I even suction? That is the frequency as well important in suctioning. The oxygen was given. This is a patient that was having 5 liters initially and was at 79 saturation. So if at all we upgrade, for example, giving the oxygen, maybe we change anything as we are coming, that has to be documented so that the receiving team can have a full detail of what happened to the patient. And of course, lastly, the recommendation basically is what do you think the next facility should do for the patient, or they should take care of going forward. Thank you so much. I'll cut it here because we have very important things ahead to discuss, and I'll come back later. Thank you so much.
Thank you so much, Mr. Okiro, for that quick and well thought through presentation. Pre-hospital care is a very important arm for emergency care. We want an alive patient that is actually going to progress through from the emergency department right to where they're going to be disposed of if in the ICU. And maybe just ask Mr. Okiro to re-emphasize for our case of the patient. I heard you emphasize 2 things. The type of the ambulance that this patient could have moved in. You mentioned a type C ambulance. I would like you to just re-echo and also put a highlighter for the people on call. Why a type C? What does a type C mean? Because we do have a lot of ambulances in circulation. And like, our problems in Uganda, sometimes they're held up by traffic. So we want the people on call to know what does a type C ambulance mean and what is going to be done in a type C ambulance and why specifically we chose it for this patient. And then the other part that I would love you to just re-emphasize for us is the part of documentation that you re-echoed a lot and emphasize. For this particular patient, what do you think is the key important documentation that should be done and should not be missed or should not be taken for granted? Over to you, Andrew.
Thank you so much for that question. The kind of ambulance type C, we have less time to really discuss much about it, but I'll give you a reference. And I would encourage us to go and check on the Ministry of Health ambulance norms and standards. So this document is there online, you can find it. It stipulates what a type C ambulance is, what it looks like, including the measurements, the kind of equipment that must be in the type C ambulance. That it is a very detailed document that can give you a proper breakdown of what not only a type C, but also other different types of ambulances and EMS response vans. But basically, just to add more on what a type C is, so this is an ambulance which is capable of delivering an advanced life support care in basic terms. Just basically that is that for type C. Now, this includes not only the aspect of the vehicle, but also the personnel you need to have in a type C ambulance. So the type C ambulance has to go along with not a first aid, of course, but someone who can be able to give as well an advanced care. And then the other question again is on the kind of information I need to capture. Again, I'll refer us to the Ministry of Health EMS HMS 002, which is the ambulance patient care form. It also has a lot of detail of what kind of care, what kind of information that the EMS captures in. So basically, it has the demographics of the patient. You need to capture them, very important. And then the assessment you've done, the kind of care you've given, the medicines you've given, including the dosages and the times. For this critical patient, that needs to be monitored after, maybe perhaps after every 15 to 30 minutes, maybe vitals have to be taken again to avoid any crashes. Again, the document has even a section where after every minute you've done something on the patient, there are specific sections that you're going to be filling in that document. And then the last part of it has the aspect of the facility where we refer the patient, who was seeing the patient, which team was en route taking the patient, what did the patient even reach alive? Did the condition improve or deteriorate? And who received the patient? And of course, finally, the receiving team has to confirm by appending their signature on it. Yeah, but you can go and check on those documents online, then you can have it in detail. Thank you so much.
Okay, thank you so much, Mr. Okiro, for that important information. So what I picked from Mr. Okiro's presentation is, one, you have to know the patient that you are transporting, anticipate your problems en route, and prepare for them. And once you've done that wonderful resuscitation or wonderful care in the ambulance, don't forget to detail and document it. And once you've reached where you have disposed or transported the patient to, you have to, one, inform them what you have done, but also suggest, because I might miss something important. You might have picked a hypoglycemia, and by the time you're coming in, it's corrected. So you need to let me know that I picked something that was important, and I would love you to watch out for it. Thank you so much, Mr. Okiro. Now, in the next 20 minutes, we are moving to another amazing part of this session, nursing care. Nursing care is a very important arm for both patients in the emergency room and in the intensive care unit. And just in the next minutes, we are going to have Miss Olive Nabirio, who is, just for purposes of reintroduction for the team that was not on, she's a nursing officer that works in the ICU at Roswell Hospital. She's an experienced person in managing critically ill patients. And she is most importantly going to open our eyes to what are the special things that nursing care involves when looking at critically ill patients that are in the emergency department to the intensive care unit. Over to you, Olive. You're welcome.
Thank you so much, Dr. Anna. My name is Olive Nabirio, like I've been introduced. I'm an ICU nurse at Roswell Specialist Hospital, and I'm going to take us through the nursing management, the emergency department nursing management of a patient with sepsis and septic shock. So many do believe that nurses themselves also do believe that nursing is all about administering medication and that is it. But we're moving from there, like we're having a paradigm shift from that to being able to be actively involved in the care of the patient. And for the management of sepsis, it's multidisciplinary, like it involves a team of doctors, nurses, laboratory staff, intensivists, among so many other healthcare professionals. And nurses do play a key role in early recognition. As we all know, nurses spend a lot of time with the patient. Yeah, doctors come and review, but nurses spend the most time with the patients. So if nurses have the knowledge to be able, the knowledge and the skills to be able to early recognize sepsis and intervene and also monitor these patients, we can have an improvement in the sepsis management and management in general. Yeah, and so in this patient, mostly patients that have sepsis do have tissue perfusion issues. And when I talk about tissue perfusion, it has to do with how much blood is reaching the tissues. And in sepsis, as our initial speaker told us, we have a dysregulated immune host response to infection. It can be bacterial, it can be parasitic, and it can be viral. And so the body is having a heightened response, like in a normal response, the body wouldn't produce those many cytokines, and then we have vasodilation. So in sepsis, we have vasodilation that is too much and then causes vessels to relax, and then we don't have enough blood reaching the tissues. And what happens? The tissues don't have enough oxygen. And so we have signs like cold, clammy skin because the extremities are not getting enough blood. We have a tachycardia because the body is trying to compensate for the blood to be able to reach the cells. And so it pumps a little bit more. And then in the event of pumping a little bit more, it doesn't have enough because the vessels are leaky, so fluid leaks in the extravascular spaces. And so we don't have enough circulating volume and we have hypotension, though the lack of hypertension doesn't let us know that this patient doesn't have tissue perfusion issues. So if you have a patient with normal BP, like the patient that we have, it doesn't mean that this patient doesn't have perfusion issues. If at all, they have a capillary fill time of more than 2 seconds. I hope you all know how to assess for that. And in case we don't, you can do a nail bed prick for like a few seconds, then you release and wait. If it's more than 2 seconds, then you know this patient is having poor perfusion. And then you have to go ahead and intervene. First of all, you can intervene yourself, and also you inform other people that are involved in the care, because you're not the only one involved in the care. And so this patient also had issues with tissue perfusion doesn't affect all organs. The brain is the one that is very, very sensitive. So most times in patients with infected tissue perfusion, you have the brain switching off fast because, as we know, how long does the brain cells take to die? Very little time. So we have to be very sensitive in issues to do with hypoxia to the brain. And so this patient was brought in with noisy breathing. I think it was noted. And then they had an SpO2 of 79, and then a respiratory rate of 46. I hope we all know the normal ranges. Like nurses should equip themselves with the normal, because there's no way you can tell the abnormal from the normal if you don't know. So it starts with knowing what is the normal. So the normal SpO2 should be ideally more than 94, like 95 to 100. But in this patient, we see 79. That is very low. And that means that the vital organs are not getting enough oxygen. That means that cellular metabolism will not take place. And if it doesn't, the cells will devise means they will produce ATP by anaerobic respiration and produce lactate, which is also not a good one. And so we also have a respiratory rate of 46. A normal adult should have a respiratory rate of between 12 to 18 or 18 or 12 to 20, depending on the source. But this is way too much. 46 is a lot. And so this patient has like, it's an emergency. Anything can happen anytime. The patient can arrest. And they also have copious secretions. Secretions can also obstruct our airway. So those are some of the issues that we have to handle. And so in nursing, it's not all about, like I said, just administering medications. And nurses should know that they can also diagnose patients and manage through the nursing process. And it starts with assessment, like we've said, the subjective data. We can assess and see this patient is having probably difficulty in breathing. They're using accessory muscles of respiration. That is the stomach and the sternocleidomastoid muscles. So if you see a patient struggling too much, you start to put question marks. And so we've already collected our data, assessment data, so we can diagnose this patient with having impaired gas exchange related to inflamed alveolar membranes, secondary to sepsis, evidenced by the tachypnea, dyspnea, and then in this case, our SpO2 was 79, and also bilateral crepitations. And then it doesn't stop at diagnosing. We must have a plan for this patient. What do we want to see in this patient? So our goal is to maintain adequate gaseous exchange with an SpO2 of more than 92, but ideally more than 94, we step at that side. And then a respiratory rate of between 12 to 20, which is normal. And then after making sure we have assessed our patient, we have a diagnosis and our goal. Now we have to do something that will help us arrive at this goal. And so we start with, first of all, assessing the airway. Like we said, we were told the patient had secretions in this case. So we can't just get secretions. We have to first position our patient in the best way possible. And also, as we're told, this patient has had a reduced level of consciousness. I hope you all know how to assess for that using the Glasgow scale. And so in these patients, we can position them, first of all, like in a lower setting whereby there are no those beds that can be able to be elevated. You can turn the patient in a lateral position to prevent the tongue from falling back. And the issue of also positioning the patient in a sit-up position, it helps the lungs expand better because the abdominal organs push down and then the diaphragm has enough space to expand. And so this patient won't struggle as much. And also it can help facilitate coughing because I don't know if any of us can cough while they're lying down, but when a patient sits up, it facilitates the coughing reflex and we can always clear the airway and secretions and enable better gaseous exchange. And then as a nurse, we also have to supplement oxygen. This patient came on nasoprongs, but then they were not sufficient because they were on 5 liters and still having an SpO2 of 79. That means that is a sign that we should advance. You don't have to wait for the doctor to tell you, now put a non-breather mask. Like as a nurse, you should know that if nasoprongs are not working, we have to advance. Because a non-breather mask offers a higher FiO2 of between 60 to 90. So we have to advance. And in this patient, we put a non-breather at 15 liters. And that helps avail more oxygen to the tissues. And then if you're able, you can draw a sample, an arterial blood sample. I don't know if many of us are conversant with that, but in case you're not, you can always call for help. And then as you do that, you can also take off other samples for CBC, RFTs, LFTs. And then the ABG, first of all, it's an arterial blood gas sample, and it helps us know how well the tissues are being oxygenated, our acid-base status, and then our lactate levels. Lactate helps us to know whether the cells are getting enough oxygen because the normal is like 0.15 to 2. So if you have a lactate of more than 2, you start to question the tissue perfusion. So that has to be intervened as early as possible. And then this one, suctioning, you have to suction the airway if you're able and if you have the equipment to do so. And then you also do insert an NPA or an OPA. I hope we all know that. An OPA is an oropharyngeal airway, and then the other one is a nasopharyngeal airway. The one that is more common is the oropharyngeal airway. And how we use it is you have to put it in the mouth of the patient. And the reason we do that is to maintain a patent airway by preventing the tongue from falling back. And so we have to also ensure that it's not too long and then not too short. Because if it's too long, it can damage our larynx. And if it's too short, it can instead just block the airway. So you have to measure from the corner of the lip to the jaw angle. And then I don't know if all were done for this patient, but ideally this is what we're supposed to do for this patient. And by the end of 15 minutes, like I said, the brain is one of the organs that are very sensitive. So we have to set goals that are goals that can be achieved within a short time. So if you put your nasoprongs, they're not working, you have to switch immediately. And then in this patient, we moved from nasoprongs to non-breather, and then still the patient was not achieving what we wanted, like the SpO2 of more than 94, and then we had to intubate the patient. And so I'll take you to the next diagnosis, which is this infective tissue perfusion, and it's so common. in most sepsis patients. And so how do these patients present? Like I said earlier, tissue perfusion, how we can tell that tissues are not getting enough oxygen is by, first of all, assessing how much is our, how is our map usually. Our map is supposed to be more than 65 in these patients. Though for hypertensive patients, you would want a map which is between 70 to 75, because patients with chronic hypertension always are used to the vital organs being perfused at a slightly higher map. So if you see a map of less than 65, you have to begin to worry. And also, I think many are asking, what is map? Like, what does MAP stand for? It is the mean arterial pressure and the pressure needed to perfuse vital organs. So we have to keep it between that, because if it falls below that, then the organs are not getting enough oxygen and blood. And so we in these patients, we see cold extremities, pale skin, mottled skin, and then we have a tachycardia of more than 100. In this patient, we had a tachycardia of 127. And so there we start to worry, because the normal is supposed to be 60 to 100. And so if we are seeing a heart rate of more than 100, it is more compensatory, like the heart is working harder to perfuse the organs. And in the event that it's trying so hard, remember, we have massive vasodilation, and so we don't have enough to pump. And so I think we shall answer the question later, that one of why we give fluids. And then as a nurse, we are done diagnosing. You have a capillary refill time of more than 4 seconds, a reduced level of consciousness. Like I said, the brain reacts faster. So if a patient starts being confused, is restless, you have to question things to do with perfusion. And then the patient, if they are conscious, they can tell you, I feel dizzy, and also they can be confused. Yeah, so you can get that from the GCS. And so our nursing diagnosis after this assessment, we have a nursing diagnosis of infective tissue perfusion related to a decreased cardiac output. And this is secondary to vasodilation and capillary leakage. These two reduce the intravascular volume, and so the heart doesn't have enough to pump. And it is evidenced by cold extremities, capillary refill time of more than 2 seconds, and then a reduced level of consciousness. And we can also have reduced urinary output, because the kidneys are also vital organs. And if they're not getting enough blood, they will also not produce enough urine. And so you have to monitor urine output also. And then our goal is that the patient will achieve an improved tissue perfusion in 1 hour. And how shall we see this? By the patient having warm extremities, we can have an improved map, a reduced heart rate, and then we can also, if the patient had hypotension, usually if they have shock, their systolic is less than 100. And so we aim at them being more than 100, but usually we consider the map a lot more, because the patient might be having the systolic of less than 100, but having a good map. So we always consider the map so much. And so in these patients, like I said, you have to assess them. You assess vital signs, because there's no way you're going to understand that this patient is having perfusion issues if you don't know the vital signs. You don't just look, you have to really assess further. And vital signs give us the objective data that we need to diagnose this. And then you assess the mental status using the Glasgow scale that has 3 parameters. It has the verbal, the eye response, and then the motor response. So if you have a Glasgow scale of less than 15, because the normal is 15 out of 15, you start to put question marks. And then you also have to do an RBS for our patient. And this all is to provide us with the baseline data that we need in our evaluation. Like I said, you need data initially to know that I'm moving in this direction or I'm moving backwards. So you need to really assess the patient. And then you always have to establish 2 large lower IV lines. And these have to be established as soon as the patient reaches your facility. Because when they advance more in sepsis, they can get to septic shock. And then there is a peripheral collapse, vascular collapse. And so it will be harder for you to even access an IV line. So the earlier, the better. If you can put an 18 gauge, better. Yeah, but 2 are better. And then we administer fluids. Like I said earlier, our mark was like if it's less than 65, and then we have signs that show that we have tissue perfusion issues. And remember, in sepsis we have vasodilation and capillary leak, and so we have to really increase intravascular volume to increase venous return to the heart. And then at the end of the day, you'll have an improved cardiac output, which will improve perfusion. And then when you're putting the cannula, you have to also take off a sample. Samples of probably a CBC, we need RFTs, we need LFTs. In general, you can just take off a purple top, red top, and then a blue top for our clotting factors, because sepsis also affects our clotting. And so we shall need those even later as we advance. And then we can go ahead and if we have to, by the way, you have to assess, because we give the fluids at a rate of 30 mils per kg. As bolus, you don't give it all at once. You can give 500, assess the patient, then you can add. So as you give, you assess, first of all, for improvement and then also for tolerance. Not everyone would tolerate a volume of 500. So most of patients of heart failure, you wouldn't just want to bag them with fluids. So you have to assess for tolerance of these fluids as you give them. And then after giving these fluids and you realize there is nothing, no improvement in our tissue perfusion, you can go ahead and introduce vasopressors. And our first line is the noradrenaline, which is given at 0.05 mics per kg per minute. And the use of this is to increase total peripheral resistance, because like we saw, there's relaxation in the muscles, in the blood vessels. And so if there is that relaxation, what the vasopressors help us do is press the vessels, and then they vasoconstrict the vessels. And then we tend to have an increased venous return and an increased cardiac output and tissue perfusion. And as nurses, you also have to insert a urinary catheter for monitoring of urinary outputs, because kidneys, like we saw, they are also affected, and the normal should be between 0.5 to 1 mil per kg per hour. Anything less than that is not acceptable and should be reported and intervened as early as possible. And we also have to evaluate our goal. And then the patient demonstrated an improved perfusion, as evidenced by a capillary refill time of less than 2 seconds, improved GCS, urinary output. These are some of the things you can look at to assess improved tissue perfusion. But in this patient of ours, we gave fluids and then we had to introduce vasopressors, but nothing much really happened. But anyways, I'll take you to the last diagnosis that I have for you for this session, and it's hypothermia, because most sepsis patients do present with elevated body temperatures due to the inflammatory response to infection. And so usually we see them having temperatures as high as 38 degrees Celsius. They have a flushed skin, and then they're febrile to touch. But when you're touching, you have to assess mostly from the forehead, because when you touch the extremities, they might be cold and you miss that. And so we have a diagnosis of hypothermia related to infectious disease process, evidenced by a body temperature of more than 38 degrees Celsius, flushed skin, febrile to touch also. And also for patients as dark as me, you may not see the flushed skin, so you may necessarily not look for it. And then our goal is to maintain a body temperature between 36.5 to 37.4, which is the normal range within the next 1 hour. And what we do, we expose these patients. You must have done this in the ABCDE. You expose the patient and assess. So you make sure the patient is exposed, and then you can tepid sponge. And the tepid sponging shouldn't be with something really hot or cold. It should be lukewarm water to avoid things like burns and then massive vasoconstriction. And then this helps us lose heat by conduction and convection. And then we can administer IV paracetamol 1 gram as prescribed. That is if it's an adult. If it's anyone below 12 years, you can calculate at 15 milligrams per kg and administer. And paracetamol helps us inhibit the COX-3, which reduces prostaglandins and also reduces the temperature set point in the hypothalamus. And we also have to, I don't know if I hinted on this previously, but then you have to take off culture samples, because culture samples help us get to know the sensitivity to antibiotics and then also prevent resistance. So we have to take off a culture and then know exactly what we are dealing with. So those have to be taken off before starting antibiotics. And we have to administer the broad spectrum antibiotics within 1 hour getting this patient. And in this patient, we also have to, in all patients, we have to assess for the focus. What is our infection focus? Because that guides the antibiotic to use. If it's in the airway, you can use the penicillins. If it's GI, you can select accordingly. So it helps narrow focus and also improves management. And also you can administer, in this patient, our focus was malaria, and so we had to administer artesunate. And what artesunate does, it generates free radicals that destroy the malaria parasites, hence reduce parasitemia. And then our goal was achieved. So the patient's body temperature reduced from more than 38 to 37.2. And I do believe this session has been of great use to nurses, and I believe we are going to be better nurses in the management of sepsis, recognition, and prompt management, truly. Thank you so much for listening. I'll hand over to the chair of the meeting.
Wow. Thank you so much, Olive. That's been very detailed and challenging. It shows us the importance of nursing care in a septic patient or a patient who is suspected to have sepsis. What I have learned from this assessment is that you do actually have to set goals for your patient. We do not do a one-time assessment, give your paracetamol and then do a good walk away. No, give your paracetamol, time that in the next 1 hour, in the next 15 minutes, I have to go back and reassess this patient and make sure that I have achieved the goal for which I did give the drug that I gave. I've given fluids, I have to go back and reassess and make sure that my fluids have actually done what I gave them out for. Yes, so that leads us into the next session. So some of us have been seeing these things and we're wondering now why the fluids, why the drugs, why the tesonet. And the next session we are diving into is going to be a discussion between, we're going to have Dr. Erasmus Okello. For the team that has not had his introduction, just for purposes of making sure that we know him, he's Dr. Erasmus Okello Erebo, senior lecturer of anesthesia, critical care at Makerere University, and he's an intensivist working at TMR Hospital. He's experienced in attending to critical patients. So we are going to welcome him, but just to open up the discussion for you, Dr. Erasmus, some of these things that we've been talking about not been making a lot of sense to us. Why do we give fluids? Do I second guess what? So maybe you can just open it up by briefly just putting into context for us in simple terms. What is sepsis? How will I know that this is sepsis? When will I say that this is shock? And how will I recognize it either in the emergency department or before the patient actually comes to the emergency department? Over to you.
All right, thank you very much. Excellent discussion so far, and thank you, Oliver, for making my job easier. That was an excellent presentation. Yeah, now it's difficult to talk about sepsis without, first understanding what brings about it. So I guess it goes back to how we evolved, and there are different theories on how we evolved. But the reality is that we are not all the same. There's different organisms around the Earth or the galaxy, and we've kind of evolved to keep them away from ourselves, or somehow at some point we establish relationships that keep us together And that symbiosis means that we coexist with those germs, right? Those organisms could be pets, but in this particular case, we're talking about microbes. Those are small organisms that live on or within our bodies, and they are normal. They can help us. Some of them help us to produce vitamins and the like that help our bodies. Some of them actually defend us against the bad organisms that want to kill us. And then there are also those that live in our bodies and we don't know what they're doing there. We're basically providing a home for them. Just like somehow we also live off other people. We're basically, not exactly parasites, but just commensals. Now, these germs are kept away from certain areas by a specific evolutionary mechanism called the immune system that keeps them where they are. And therefore, they're supposed to cross certain boundaries. Similarly, there are germs that cannot even coexist with us in that proximity, so they live in the environment. And so the only way they get into us is through some sort of transmission, either through us ingesting them or somehow some injection into our body. Now, when these enter our body, our immune system doesn't like it. It gets activated, it tortures them and tries to kill them. That's called the immune response. And usually that's enough to clear these germs. Sometimes it's not enough, so we need some help from simple things called antibiotics, chemicals that kill these germs. What I'm talking about is called an infection, invasion of an otherwise sterile environment in our bodies by germs. And usually our immune response is classic. It's a well-organized intervention that helps our body clear these problems. Now, occasionally the infection is quite severe. It's quite a stubborn one, or whatever characteristic it has, or whatever chemicals releasing are quite toxic, so bad that the immune system gets extremely confused and activates its last fight, the most florid of its responses, which is basically what you call a cytokine storm. So somehow, through fairly understood mechanisms, our body activates a very robust immune response that destroys not only the germ, but also part of our body. That destruction causes injury to our body systems, starting with the inner lining of the blood vessels, something called endothelium, and therefore induces so many other reactions that lead to organ dysfunction. Therefore, organ dysfunction resulting from a florid, dysregulated immune response to an infection that you know about or you suspect to be existing is what is called sepsis. So sepsis is not pus in blood. Sepsis is not bacteria swimming in the blood. Sepsis is organ dysfunction due to a dysregulated immune response to an infection. And that means your own immunity is torturing you in a process of trying to repair, to fight back against it, and infection that's torturing it. So when this happens, it means all tissues in the body are going to suffer. Some tissues are crybabies. They immediately show that, no, they're not happy. The brain doesn't have it on reserve. The moment you torture it, it starts showing its complaints. So you start getting confused, disoriented, and your mood changes. You hate everyone, and of course, if it's so bad, you might end up in a coma and even die. Your lungs are supposed to exchange gases. And that exchange means there's an alveolus on one side and there's a blood vessel on the other side bringing blood to pick up oxygen. This disruption here means the interplay between the two is going to be disrupted, and that means you're going to have gas exchange issues. If you go to the kidneys are supposed to be filtering blood happily, but also you're going to have injury to that microcirculation, and that's going to cause problems. If you go to the heart itself, the vasculature is going to be injured, and that's going to affect how it responds and conducts blood around. So you're going to have multiple issues, the skin, the gut, everything else. However, in a way to stay alive, your body will try to redirect all the essential nutrients, resources towards the vital organs. And so blood flow is diverted from the skin, from the gut, towards the central organ, you say the brain, the kidney, the heart, the lung, to keep you alive. That means now these other organs will function less. For example, most people who get septic will not be able to have good gut function, so they'll end up with nausea, vomiting, loss of appetite, and the like. People will have horrible skins, they take whatever cosmetics they are, but it's really horrible in that moment. And so that's how it's supposed to be, right? However, sepsis is so unique. Sepsis means, on the circulatory perspective, this disruption of the way the circulatory system conducts blood and the way it prioritizes blood flow. Usually, in terms of stress, you're supposed to direct blood towards essential organs I've described. However, what happens in sepsis is that there's a mess towards the blood vessels that conduct blood to the essential organs. So blood is redistributed to non-essential organs. So you're having the skin getting too much blood flow, the skeletal muscle getting too much blood flow, and yet the brain, the kidneys, the heart are getting starved of this blood flow. So you have this vasodilatation with poor perfusion of the central organs. So the skin gets hot, the pulses become very strong and bounding, right? And yet the flow in the micro circulation, the small vessels that deliver blood to the cells, is quite poor. So you notice if you're very light skinned, you probably notice some sort of darkening, dark lines on your skin, something called skin mottling, especially around the joints. Those are signs that tell you that, this person's circulation is quite poor. You go into areas like the brain, of course, not functioning well from poor perfusion, but also from the chemical reaction that's happening, that's the immune response. The kidneys can no longer filter enough, so the urine output is going to be low. Because you're not sending blood to these good organs, the compensatory mechanism says, hey, I need to save myself. So you fire up your sympathetic nervous system to try to drive blood flow where it's supposed to be. The consequence is that the heart's going to be beating very fast. But also, that's not going to achieve what you want. It's going to continue. The tissues are going to be poorly perfused nonetheless. The consequence now is that you're going to have too much production of lactic acid. And that lactic acid is not just because there's little oxygen. It's because there is increased production of adrenaline and noradrenaline running to tissues and stimulating a compensatory mechanism. That mechanism involves so many biochemical reactions, but also one that includes increase in glycolysis, meaning that you're trying to produce a lot of energy. But the Krebs cycle is not active because it's not made oxygen delivery. So all the pyruvic acid that you produce from glycolysis ends up diverted towards lactic acid as a way of survival. So the lactic acid increases significantly. So how do you recognize the patient has got sepsis? First is you want to recognize the patient has got an infection. How do you know the person has infection? It means a germ has snuck into the body. And that reaction that you get is signified by the SAS criteria. If the patient has got a fever, if their white cell count is either going up or going down, the temperature, they might be breathing rapidly, maybe the heartbeat is changing and so on, right? We remember that from a SAS criteria. But then now, once they have reached the point of sepsis, now there's going to be evidence of organ dysfunction. So you're looking at organs getting dysfunction in this person with the due to poor perfusion. In that case, you're looking at old alimentation, you're looking at a patient with a rapid respiratory rate because they're trying to compensate for the acidosis that's happening. That's even besides the changes in the oxygenation that happen in the lungs. And then finally, their blood pressure may also be disturbed as a result. So we would open very big textbooks of medicine to understand how to recognize this. So to make it easier, there are so many algorithms that have developed to try to narrow the recognition quickly. So for a patient you know who has an infection, be it from malaria or be it from a bacterial infection or a viral infection, once they have old alimentation, in other words, a GCS less than 15, patient has got a rapid respiratory rate, more than 22. For an adult, or maybe the blood pressure is less than 100, systolic. That patient, if they have two or more of those features, the patient must be having sepsis. And we prefer that, there are so many other reasons the patient can have these particular clinical signs. But if there are clinical signs, you have two or more in a patient who has got an infection, then most likely you're dealing with sepsis. And sepsis is extremely deadly. We've been given an introduction to it already, and want to recognize it early and intervene early. And that's why we go with what's called a quick SOFA. What happens is a quick SOFA. It's really 3 parameters which you can measure bedside. A patient's mentation, patient is disoriented or has got reduced GCS for some reason, patient is breathing rapidly, respiratory is more than 22, and their blood pressure, systolic is less than 100. 2 or more of those suggest the patient must be septic. And that means you must rapidly escalate your interventions. You intervene rapidly, save them from danger, because if you delay, they're going into multiple organ failure, from which point the best interventions will no longer be useful. Thank you.
Okay, thank you so much, Dr. Erasmus, for that elaborate introduction to the discussion of sepsis. I would like to invite Dr. Shevin, being an infectious disease specialist. I understand there is a concern that every time we see sepsis, most people will think about bacteria. What's your experience on the occurrence, the epidemiology? Do we often get sepsis from other culprits, the fungal, viral? If it does, which populations do actually get this often? And then is there presentation in the emergency department or even in the hospital? Is it any different? Are there special things that would say, this is most likely bacteria before I go in the investigation part? Is there a heads up that you can give us that could make us think, this is mostly bacteria, this is mostly viral? And then 2, on top of that, if I were to choose to take care of these patients, from your experience, there was one time that theory of was to get a septic patient, give antifungals, give antivirals, give antibiotics. Just from your experience, how do you approach these patients? Firstly, for the epidemiology, and then the management.
Yeah. I have some slides that might help with this. Should we come to those later, or what would you think, Jim? All right. Just as I answer your questions, I mean, it's the key and one of the most critical, important parts in terms of the management of sepsis. Though it's not the only part, and so this, to be clear, are the wonderful presentation from Olive and Simon and now Erasmus about management, thinking about sort of all the organ systems more comprehensively is critical. But as we know, the inciting factor for sepsis is an infection, an underlying infection, and understanding the what might be the cause is really important. And that cause, that etiology, varies where we are in the world, where you are in Uganda, and who the patient might be. As you just suggested, there may be particular patients who are more prone to certain infections than others. I think, why don't we just can advance, we'll skip this stuff because I think a lot of this has been, yeah, this is a slide. I just wanted to start with that one, sorry, Jim, or the one before. Yeah, great. So this is just one example. This is a study that was done in Tanzania of hospitalized patients with hospitalized adult patients with fever, and there's just some key take home points to bring home from this figure. The first is that the 61% of the 400 patients that were enrolled in this study were initially thought to have malaria. And so I think, you know, there's a challenge in many settings where we use the term malaria interchangeably with fever. And then that, you know, as we know, fever is a symptom. It can be a sign if we're measuring hyperthermia, but it's not the same as malaria. Malaria requires a pathogen to make that diagnosis. And so in this particular study, although 61% of these patients were thought to have malaria, only 1.6% of them actually had malaria. So what else did they have? We talked about, Olive brought up the importance of having blood cultures before you start your antibiotics. And in this case, in the bloodstream infections, only 28% had a positive blood culture, which can be bacterial, which can be fungal. And I'll say a little bit more, but within the bacterial, it could be mycobacterial. And the other part here is that 33% in this study, and as is shown in multiple other studies, so about a third of patients don't, no matter what test you end up doing, testing from the blood, testing from the urine, testing from the sputum, you don't identify an organism. So the questions that Dr. Anna are mentioning, you know, what are we supposed to do empirically? What kind of treatment should we be providing? And then the last part to point here, so this is in a kind of rural area of Tanzania where they had additional access to tests like serologies, so PCR testing to look for things like rickettsial diseases, like viruses like chikungunya, other bacterial like leptospirosis. And by looking at these zoonotic diseases, these is diseases that are sort of where animals are in the chain of transmission, 40% of the patients were seen to have, that was the cause of sepsis or the acute febrile illness in these patients. And so just to say, in this particular study, the differential diagnosis was extremely broad, right? You have, bloodstream infections, you've got zoonotic diseases, and this is not even all of the tests that can be done. So I think the first point is that, while we might be dealing in a particular hospital that has resource constraints beyond, as to the kind of test that they can do, it may need to be at a district level, at a regional level, at a country level, really trying to understand what are the different pathogens that we have that are most common, whether they're bacteria, but also thinking about other, viruses. The question of dengue comes up often. In Uganda, dengue is not as common as you might see if you are emergency department physicians taking care of patients who come in with a sepsis syndrome on the Kenyan coast or the Tanzanian coast. So, they are seeing people who are different, but in their differential diagnosis, someone who's coming in with organ dysfunction and a suspected infection, dengue needs to be in that differential diagnosis, whereas here in Uganda, it might be a little bit lower. And so the key is to try and have these, what we call sentinel sites, and that can be, again, depending on what you have at, whether at the regional level or at the national level, really trying to put together what are the most common causes of pathogens and who is affected by them. So we can go to the next slide and I'll say a little bit about that who. That just kind of simple pie chart before we advance, maybe just don't advance that first. Okay, so just the first time. This is from a study that we did here at Malagma Hospital and Masaka Regional Referral Hospital over 10 years ago. And it was a study, again, of patients that had suspected sepsis. And what you're seeing in that figure are patients who were HIV infected. And so, not surprising that you see a number of gram-negative and gram-positive, like Strep pneumo, Staph aureus. The gram-negatives are E. coli, Pseudomonas, also some Salmonella were identified, and even Cryptococcus neoformans was identified in the blood in a subset of patients. So certainly there are a subset of patients where in the usual blood cultures, you would have been able to see things that you typically treat for with the bacteria that we have. But I also want to raise the importance here that again, we have a lot of negative cultures. So, and so that might speak to people coming to the hospital already having treated themselves, self-treated or had access to antimicrobials before arriving at the hospital. But it also might mean that there are particular pathogens that can grow on the usual blood cultures, whether those are viruses, and also slow-growing bacteria and other pathogens. An example of that is what you're seeing in that blue part of the pie chart, which is Mycobacterium tuberculosis. And this is critically important in this setting and in other settings where HIV infection is highly prevalent. Because what has been seen in a number of studies across countries in sub-Saharan Africa where HIV is prevalent and TB cultures have been tested in the blood, the number one cause of sepsis in HIV severely immune compromised patients is TB. And you can advance that. So here is a systematic review that myself and colleagues had done, and this included data from Uganda, but also from a number of other studies where TB bloodstream infections were evaluated. And what this figure is showing is that people who have TB bloodstream infections versus those that don't have bloodstream infections. So as you said, the denominator in this case was patients with TB infection. So it's a little bit different than what I've been talking about before. But if you had TB in the blood, so bloodstream infections, you can see that there's a statistically significant difference in your mortality compared to if you don't. So TB sepsis is a very important entity that we don't talk about a lot. And certainly, as you all know, in our empiric treatment of patients with sepsis, the patient in front of you with suspected sepsis, it doesn't include treatment for TB. And so this is just something I want to raise here because these are data that are from Uganda, for patients who continue to be immune compromised. Certainly, over the last 10 years, the access to antiretroviral therapy and the numbers of HIV-infected patients who have severe immune compromise have decreased. But you still see patients, in your emergency department, in your hospitals, who are severely immune compromised. And so those are the very patients where you need to start thinking about TB. And in fact, in the national TB and HIV guidelines, if you have a patient who has severe HIV and kind of systemic disease, you should be thinking about disseminated TB. In patients who have severe, severe immune compromise who are HIV infected, they should be getting a urine lipoarabinomannan test. This is available from the Ministry of Health. So if you are not using these, you should be using this. It's an antigen test that can be tested in the urine. And it's very effective in diagnosing TB in patients who have a low CD4 count and who are HIV infected. So if there's a question about whether or not to start TB treatment in one of these patients, you might consider getting the urine LAM test to help drive that. There's a longer conversation about what TB treatment should be done, and I don't think we have time to discuss that. But I really think that given this setting and the high prevalence of HIV, that in addition to what you're thinking about for your usual gram negatives and gram positives, please consider TB in your very ill immune compromised HIV infected patients. The last thing I'll just mention, there's a lot of discussion around antimicrobial resistance, and yeah, you can advance that first one. Yeah, and just before. Thanks. Yeah. So in that figure there, what this is showing is the mortality from drug-resistant infections around the world. And on the left side, those green bars all represent the kind of different regions of sub-Saharan Africa. So the greatest mortality due to drug-resistant infections in the world is in sub-Saharan Africa. And so we really need to be aware of not only that the patient has sepsis in front of us, and not only that, what are the most common bacteria that they're causing, that are causing the sepsis, but also be aware of the antibiogram or the susceptibility of these typical organisms to the available antibiotics that you have. And so as we're thinking about, in totality, what are the kinds of treatments we need to provide? One, we need to be aware of, sort of the microbial milieu, or kind of what is the typical pathogens that are out there, but as well, the drug-resistant pattern, what are the antibiotic susceptibilities, so that we can target the bacteria with the appropriate drug. And then also think of our broader differential diagnosis. Maybe you won't be seeing rickettsial diseases in Kampala, but you will be seeing them in more rural areas. And these are tick-borne diseases where, addition of doxycycline could be a matter of saving a life in certain areas. And so understanding that whether those are contributing to sepsis cases in your setting is going to be really important. I'll stop there. I think there's a lot more to say there, but I'll stop there.
Okay, thank you so much, Dr. Shevin. I think that has highlighted something very important, and I hope our questions are answered on the themes that we're thinking. Sepsis equals antibiotics. So this is a good eye-opener to us. Over to you, Dr. Erasmus. Can you highlight for us, given our patient and also from your experience, just open our eyes to quickly highlight on the 1 hour sepsis bundle, and then the ongoing care, and then quickly also delve into the choice of antibiotics in case it's a bacterial sepsis. And then fluids. Yeah, fluids for the patient. Why? Which fluid? And then does the 30 ml package apply to every patient? Yes, what are your thoughts on that?
Excellent. So again, we said sepsis kills, and therefore we must intervene as though we hate it. And that means the intervention has to be quite rapid. Different authorities have come up with different statements to support the timely interventions in sepsis. Hence, the things like a 1 hour bundle that's promoted by the Surviving Sepsis campaign. There's been a 3 hour bundle by the emergency medicine response authorities and the like. And there have been so many different ones. But the idea is this time is tissue, and you must respond as aggressively as you can. So the 1 hour bundle basically talks about the timely intervention must start in the patient of diagnosed with sepsis. But I like to go first principle. The first principle approach is what we saw in the case presentation we had. A patient who is at risk of dying, that's an emergency. So we approach it in the way we manage emergency. So airway, breathing, saturation, disability, exposure, and then perform a secondary survey. In the airway, you want to make sure that this patient's airway is parted and attend to it, as we had from the case presenter, as well as Oliver's presentation. You want to make sure that you're providing adequate oxygen to these patients. You know, the saturation is helpful in these patients, but remember the delivery of oxygen is a problem. In the process of oxygenating tissues, there are 3 very important things that are relevant to making sure you are okay. Number 1 is that your cardiac output should be good, your hemoglobin level should be fine, and the oxygen saturation should be good. So the breathing part, whereas it's really looking at making sure there's adequate delivery of oxygen to tissues. That means put oxygen in at an adequate rate to make sure the patient is saturating well with oxygen, and that oxygen is being delivered to tissues in the C in terms of the saturation, where you want to put an IV access to this patient. Large access, meaning preferably the largest appropriate for the patient. I'm not saying putting the gray cannula in a neonate. I'm talking about putting the largest appropriate for the patients. In adults, you should be looking at the gray cannula when it's feasible. When you cannot get access quickly and the patient is very sick, then you probably want to put an intraosseous if you can have access to it. And that is unfortunately a problem for most of our settings. We may not be able to access intraosseous devices, do it rapidly, but any line the patient has is important for starting resuscitation. And then take off blood work from the patient. As we were told before, start them on IV fluids. So IV fluids are going to be appropriate for a patient you have assessed to actually be, technical, let's say, hypovolemic. So there's a difference between rehydration and correction of hypovolemia. Hypovolemia talks about the blood volume, the amount of blood circulating through the patient's blood vessels and supporting hemodynamics. Dehydration is loss of hypotonic fluid. A patient who has been hasn't been feeding for a while, has been sweating because of sepsis, they're having fever, maybe they've been hyperventilating, they had diarrhea, or maybe doing diuretics, they've lost hypotonic fluid. And so the cells are getting contracted due to loss of volume, and the blood sodium level, extracellular sodium, is getting concentrated. So technically, the definition of dehydration means a patient who has lost volume and is having hypernatremia. Short of that, you're dealing with other fluid losses, particularly in a patient who's in shock. The primary goal here is to restore circulating volume, and that's why we go with isotonic fluids. So how do you know a patient is hypovolemic? This is a patient who might have all the signs of a patient with reduced stroke volume. So they are tachycardic, the extremities might be cold and thin and thready pulses, like the case we presented, And this is really important for us because every time we think about sepsis, we're all thinking must be bounding pulses, must be warm extremities. But sepsis is a syndrome, it's not a disease. It's a syndrome where there can be different aspects involved in circulation. On one side, you have vasodilatation. On the other hand, a patient has vomited, has been having diarrhea, has not been feeding for a while, and so they're hypovolemic. On the other hand, sepsis through its cytokines, cytokines that are released, but also endotoxin itself can mess up with your heart. So you end up with septic cardiomyopathy, where the patient presents with heart failure a heart failure picture in a sepsis. The heart's not pumping well. These are rare, but late signs. And it's especially common in people who are at risk of them. For example, we see it in people who are postmenopausal, the elderly. These guys' hearts break. That's called broken heart syndrome. We see that a lot. These are guys you give fluids, they're still getting worse. You've given them 2 liters, 3 liters, 4 liters of fluid. They're getting worse. In fact, soon they'll be having pulmonary edema, but the hemodynamics are getting better. Then, because sepsis means fluid inflammation, and activation of all different cascades. One of them is thrombosis. These people are also at high risk of getting thrombi, one of which is possibly getting a PE, which is why, again, they suspected in this case. So when you're assessing these patients for hemodynamics, your worry is, one, how are the extremities? If they are warm, the commonest warm shock the patient has is sepsis. So start them on a pathway of interventions for vasodilatory shock. That means IV vasoconstrictors, maybe fluid if they are volume responsive. Volume responsive means if a patient is breathing, they're breathing rapidly. You look at the pulse oximeter waveform, and that waveform is shifting in inspiration and expiration between large waveforms and small ones. It means if you give them fluid, most likely they might benefit. On the other hand, you can also do what's called a passive leg raise, where you lay them down and passively raise their legs. If the blood pressure, if the pulses improve. If the pulse waveform improves, then most likely you are dealing with the patient's fluid responsive, and giving them fluid might help them. On the other hand, if you do all that and you're getting better, maybe not giving fluid is helpful to this patient. You need to focus on other interventions. They could be in the cardiogenic side, or the referring facility has given them a lot of fluid already. And now what you're going to do to them is going to push them over the edge. Nonetheless, in the 1 hour bundle, it's a recommendation of starting them on about 30 mils per kg of fluid. That's about 2 liters. That is okay for most patients, but there's a category that you need to pay attention to before you do that. Thankfully, in Uganda, our crystalloids come in 500 ml bottles. Where shaving comes from originally, actually it's Ugandan, but essentially in the UK, North America, and so on, they have these big bags of saline or Ringas lactate of about 1 liter. That means you open it and all goes in. Now, if the patient just needs an additional 500 mils, you've pushed over the edge. Now you're going from hypovolemic shock to fluid overload, and now you have more problems. So in our setting, you give a patient a bolus of 500 mils, and then you reassess the parameters of perfusion. Number one, microcirculation. What's the capillary refill time looking like? If it has improved, stop there. Your job is not to restore all the volume at once. It is to restore perfusion, save organs from failure, and then continue treatment. Eventually, the fluid status will be restored with time. If it has not improved, give another bolus, okay? Blood pressure, remember, I'm talking about is only secondary. Blood pressure will go to perfusion. Your interest is tissue perfusion. Look at capillary refill time. Look at mentation, urine output. If you give a bolus and those improve, it means you're doing well. If you measure lactate, it might help you to give you a clue that the patient is under a stress that could cause them to produce lactate. It doesn't necessarily mean that they're actually not perfusing tissues, because there are other reasons they get a high lactate. And giving them fluid doesn't clear lactate immediately, okay? So following lactate as a trigger, the patient could be very sick, is helpful. But following it closely to guide you on giving more fluid might cause over-resuscitation. So now we have a new study. Okay, well, not a new study as such, because we've had this study before. The Andromeda shock study promotes the use of a clinical sign, capillary refill time. Oliver just talked about it, where you compress the nail bed and see how soon, you compress it for about 5 to 10 seconds until it blanches completely, and then release it. Now, some of you are very strong, and that means sometimes you can actually compress and it remains ischemic, even if the patient has good perfusion. So an Andromeda shock study has standardized the approach, meaning you should have a glass slide. Get a glass slide, use it for compression. If you apply enough pressure to the nail bed, okay, and it blanches on the glass slide, it means that's adequate pressure. When you release it, it should refill within about 3 seconds or less. If it reveals later than that, that most likely means there's a problem with microcirculation. Now, capillary refill time is great because telling you there's a sluggish flow through a microcirculation. But does it also mean that keep giving fluid. Before you give the next fluid bolus, please check, is the patient still fluid responsive? Because it might mean that the patient is persistently in shock, not necessarily because at this stage they're still requiring fluid, but maybe now they need to step up on your vasoconstrictor. So you start them on noradrenaline. Noradrenaline now constricts the vessels. Remember, whereas vessels are dilated all over, the arterial side and the venous side, most of your blood, 70% of your circulating blood is on the venous side. And those the veins have got alpha-1 receptors, which are stimulated by noradrenaline. So administering noradrenaline predominantly improves your cardiac output by squeezing the venous circulation to return blood to the heart rapidly. So the preload is improved, stretches the heart nicely, and therefore the stroke volume improves, and so your cardiac output improves. By so doing, the capillary fill time improves because of this rapid flow of blood towards it, and things improve. If you do that, and it is improving, then perfect. Now you go back and keep looking for other mechanisms of the shock and stabilizing it. If it does not improve, or it's only getting worse, then maybe your patient actually has a cardiogenic component, and maybe you need to start an inotrope, right? Along with that, if you're requiring increasing dose of noradrenaline and the like, maybe you might have to start a patient on a steroid. And so sometimes you start a patient on steroids just to dampen the immunological response, just to enhance the vasoreactivity to the inotropes, and also to improve the retention of salt and water in the vessels that eventually improves the hemodynamics. Remember again, we take sepsis means endothelial damage, and that means the soul leakage of fluid out. Steroids might help to stabilize that. So this is what you do with hemodynamics. Then you want to you want to provide the hemodynamic support. Then remember, the trigger is an infection. Beyond starting antibiotics is identifying the source and controlling that source. We will scream and be excited about the beautiful antibiotics we have, and some of them are very nice names, and some of you guys are attracted to names because the medical reps are telling you about these beautiful names of antibiotics. But no, finding the source of an infection and controlling it is the key. A patient who has got an abscess is not going to get better regardless of your antibiotic unless you drain out that abscess. So examine the patient thoroughly, find the abscess and drain it. Of course, take off a specimen from it for culture, take off blood for culture, and start them on broad-spectrum antibiotics. Which antibiotic you choose, we shall get back that in a moment, because it depends on the site of infection and other risks the patient might have, as we've already been told by Shevin. Of course, place the appropriate lines. You might need to press us, and we know that if you run pressors for a long time through a peripheral line, then your patient might actually end up with the extravasation, with some other adverse events. So if you're in an appropriate center, then maybe you might want to put a central line in the patient so that you can run pressure through that line while you use the peripheral lines for volume resuscitation. Remember, peripheral lines, because they are short, they are wider bore, they are better for volume resuscitation for this patient. And as you do all this, it's around the clock intervention. You intervene, you assess. You intervene, you assess. When you find something does not work, you go back to reevaluation. And you don't leave the bedside until the patient is out of shock and the patient is stable. So essentially, that's what you capture in the 1 hour bundle. And I'd like us to go with the common sense approach, because when you forget a component of the 1 hour bundle, some of you guys get lost. For sure, you can Google it up, but the reality is, identify patients who's in shock, resuscitate immediately, and then identify the source and start them on broad-spectrum antibiotics in a timely manner, and then start planning the long-term support.
Okay, thank you so much, Dr. Erasmus. That was very elaborate.
Fluids.
Pardon?
Regarding fluids.
Oh, yes, a minute to discuss fluids.
Correct. So regarding fluids, the reality is we now know. Back in the day, we used to pour water into patients and flood them. But now we know that we probably don't need too much fluid in these patients. A drier patient, or one who's just appropriately hydrated, is appropriate for recovery. If you overload the patient, they get edematous and the like, then you're killing them. Sepsis activates the stress response, meaning the patient is going to retain water and salt. So in a day or two, they are measuring baby, swelling all over the body. So you want to give just appropriate fluid to restore perfusion. Now, because of that, the amount of volume of fluid we give patients for resuscitation is far less than we used to give in the early 2000s or in the early 2010s. That means 1 liter of fluid might be enough to pull a patient out of shock, and then you proceed to the next step of sustenance. So we probably don't see significant difference now between normal saline versus balanced solutions. However, when you have a patient who is going to require more than 2 liters of fluid in an hour's period, it means if you give them normal saline is actually abnormal saline. It has got an extremely high chloride content, more than what is physiological. So that chloride is going to accumulate in the patient and cause hyperchloremic acidosis. But chloride also affects coagulation. It affects the kidneys. It affects tissue healing. We don't want it. So balanced solutions have less chloride, have other electrolytes and other components that resemble what's in the bloodstream. Ringer's lactate, for example, has got potassium, has got calcium, but also has lactate. Lactate is a precursor of when metabolized to bicarb, and therefore it actually helps the acid-base picture of the patient. And that kind of saves the patient from getting into other complications. So that is really why we prefer balanced solutions in large volume resuscitation compared to normal saline. But there will be a patient who might need normal saline. A patient who has been vomiting profusely, has lost chloride. Okay, a patient who has got traumatic brain injury and also sepsis does not want their sodium to drop so rapidly. So maybe normal saline will be better for them because it avoids the secondary complication of hyposmolarity and brain swelling. But these are very few patients. Most patients are likely to benefit more from a balanced solution in large volume resuscitation than normal saline.
Okay, thank you very much, Dr. Erasmus. Our time is fast spent, but before he leaves the chair, I would love him to highlight 2 things, each in a minute. One, what's your take on the special populations, the pediatric population, the pregnant woman with sepsis, then we do have the elderly, and then the second one is on the take on the use, the patient who you've done the medical management and has failed, the use of immune modulators. Are they available in Uganda? What's your experience? When should the person start it? Should we start asking the government of Uganda to give them to us? What's your take? Just quick.
Okay, so you've highlighted a number of parameters that I hope I'll capture quickly. So starting with the special populations, children are small, adults, and pregnant women are not just people carrying a parasite. No, it's altered physiology. Elderly definitely have altered physiology too. And the approach, as I mentioned, is a standard stepwise approach where you're assessing the patient, determining the physiological derangement you want that you see, and intervening as appropriate. In children, the same principles apply. You do not just put fluid. You want to evaluate and see, is this patient likely to benefit from fluid at this stage? Maybe one moment they are benefiting, next moment they are going to be harmed. You have to step aside. We know from, for example, the FIST study that giving too much fluid to children actually killed them, and that's because we tend to overshoot and then they're going to failure. Sepsis in them presents slightly differently because their vessels are not their vessel is not as broad as the adult. So they may not present classically with the vacillatory picture. They might end up going quickly into cardiogenic shock. So resuscitating them early helps, and yet they respond quite quickly and deceive you, and you think they're getting better, and yet you need to continue on the pathway of intervention. Elderly have multiple comorbidities. They may not handle the fluid. The heart may not be happy. The vessel pressure might actually drive them more towards ischemia because they have peripheral vascular disease, coronary vascular disease, and cerebral vascular disease. So being very active bedside in assessing the parameters of perfusion when resuscitating helps. And they have limited reserve. They have eaten their reserve over the years. So that means every second counts. You delay, they are losing more tissue. And so you want to intervene in a timely manner. That's what I would say for the elderly and children. Now, pregnant women have altered physiology where their normal cardiac output has probably gone higher than usual. So by the time they go into shock, it means they've lost a lot of volume. Maybe they are vasodilated and they've been sick for a while because they have all this altered physiology. Their breathing is slightly different from ours. They can have a physiological respiratory callosis. So again, when you're approaching them to understand the basic physiology helps. So how do you do it? Don't manage them alone, okay? These are kind of patients where you want to include colleagues quickly so that you're walking the journey together, and hopefully even transfer to a specialist center early enough, because like for pregnant women, you're caring for 2 patients and they both want to go home healthy, okay? And so you want to optimize outcomes for both of them. I don't know if that covers it enough, but in case there's a gap, I'll mention. Regarding immunomodulators, it's a subject that science is looking into quite a lot. We know there's a florid immune response, and we know that immune response to infections, there is both activation of the pro-inflammatory pathway and the counter-inflammatory pathway together. And so your phenotype depends on whichever is most activated. In people who are floridly immune activated, it suggests that it makes sense to probably dampen it a little bit. But when to dampen it matters, because remember, this immune response is meant to clear the germs. So you might immunosuppress the patient, and that now makes the germ gains more momentum. Then you might delay, now they end up with more organ dysfunction. So many agents have been studied for immunomodulation. And I would not like to say that the results have been very reassuring for all of them. If anything, maybe in the case of steroids, there's actually been quite significant evidence there that they're quite useful in different areas. There are other immunomodulators that we have, like in our market here, people you're using a drug like uromodulin. I don't know its trade name in the market that they're trying to use, but the evidence for its use is not very strong. There are specific conditions where maybe using anti-inflammatories might be very helpful. Like in the cases which are driven by toxin, you could use IVIG and other things. But specifically in sepsis, the goal is organ support, source control, and starting a timely intervention and sustaining organ function long enough for the body to eventually settle. That's really where it is getting worse, the patient requiring more pressors and so on. Steroids might be helpful. And that's the kind of patient, because they're requiring more pressors, they're developing ARDS and so on, then perhaps this patient might need some steroids. Yeah, but usually you don't want to start outright by giving them these therapies. Yeah, so it's not a very promising area, and we like to keep it as simple as possible. So have few interventions that you know about, that you use quite regularly in a timely manner, and you save most patients.
Okay, thank you very much, Dr. Erasmus. That was very educative, very simple. We are coming to the end of our session in the next 5 minutes, and I would love to appreciate our team of panelists. Thank you so much for taking up time to give us your knowledge on sepsis. Sepsis has not ended. We're going to highlight ourselves a bit more. For the team that is on the call, there is a post-test that is running. Oh yes, we're going to go through it quickly. I'm going to use a few minutes to run through it. So the first 4 questions that we had, 1, what are the imminent emergencies that our patient had? And our patient had one, a threatened airway. We were hypoxic, we were in shock, and we had altered mentation. A majority of us, and were in shock. Majority of us were able to get that right. Our next poll question was the management of the patient who had the emergencies. Next poll question, please. Yes, majority of us equally got this. 78% of us got the question right. We were able to recognize that we had a threatened airway, so we had to suction, we had to start fluids. Next, okay, the next question was management. So our answer was the one that had positioning the patient, suctioning, starting IV fluids, and majority of us got that right. Next poll question. Our third poll question was on the management, I presume.
Essential bedside.
Yes, bedside investigations for this patient. And I think also majority of us were able to tease out that we needed to have a random blood sugar, have an RDT, an ABG, and do a bedside ultrasound scan. We're unable to elaborate on ultrasound using the emergency department, but it's a very important tool. Dr. Erasmus kept re-emphasizing on fluid responsiveness, and point of care ultrasound. If you're in a facility and you do have the skill, please use it. So we've come to the end of this session, and in 1 minute for each of these panelists that have been present, I would love you to tell us what's your key message that we love the team that has been on this call to go away with. This time I'll start with the gentleman. Mr. Andrew, please, what's your take-home message in 1 minute?
Thank you so much. My take-home message is hygiene is very important, and IPC. Because now when we talk about sepsis, infection, so that means you have to make sure the ambulance is clean, but also IPC. There's this infection might pass on to you as well.
Okay.
And then preparation is very key for any response. Thank you.
Thank you. Dr. Shavin?
Yeah, I think we covered the complexity of sepsis patients and reminding us that sepsis is a medical emergency. And so as that is the case, when the patient comes to the door, that's not your only assessment, right? You have your baseline assessment, you have the primary survey, you'll do your ABCDs, but just remember that everything that you're giving, including fluids, including the antimicrobials, those are medicines. And you have to assess the patient again. That should be part of your management. That, you know, it's a loop, PDSA loop, where you're going and seeing, I've given a treatment, I've given fluids, has the patient responded? If they haven't responded, I have to do something different. I've given oxygen, the patient hasn't responded. So now I need to escalate to a non-rebreather, or the patient is responding, and I also need to decrease the nasal cannula oxygen or whatever. So all of these things, just we need to think about systematically in terms of all the different treatments we're giving, all the different assessments that we're doing, and not forget that over the course of the hospitalization, we are obligated to go back and make sure that the patient is responding, and if they're not, determine what the next course of action is.
Okay, thank you so much, Dr. Shavin. Dr. Ambrose? Sorry, Dr. Kelly.
Erasmus here. Yes, so time is tissue. Intervene in a timely manner, keep running around, sepsis kills. And it means that you should treat as an emergency, the same way you treat a cardiac arrest, same way you treat a stroke. You should be having a code sepsis. And so you must have all members of the team alerted to the acuity of the problem that you have. Sepsis is not pus in blood. Sepsis is not bacteria in blood. Sepsis is organ failure, organ dysfunction as a result of your own immune response to an infection. And therefore, it goes beyond just treating the infection, and any kind of infection can trigger it. So stay woke, stay active, and let's save more lives. Thank you.
Okay, thank you so much, Dr. Erasmus. Olive?
Yeah, like I introduced myself, I'm Olive, and I work at Roswell. My take home from this session is to all the nurses out there. Sepsis is multidisciplinary, and it requires everyone to be actively involved, including nurses. It shouldn't be just waiting on the doctors to prescribe, like we should actively involve ourselves. We assess our patients, because a doctor might miss something, but we are always with the patients 24/7. So we always have to be active in the management of sepsis, because early recognition is what saves a life. Because when you recognize sepsis early enough, you prompt management. You may not be the sole person managing the whole thing, but you involve other healthcare professionals, and that early recognition that you've done will save a life. And I hope you've picked a lot from this session that is going to save so many lives out there. Thank you.
Thank you, Olive. Dr. Simon?
Thank you, Dr. Anna. I think my take home is, I just want to re-echo what Dr. Erasmus has said. The take home is the definition for sepsis. It is multi-organ dysfunction due to a dysregulated host response to an infection, which is not, an infection is not equal, I mean, like, sepsis is not equal to pus in the brain, just like Dr. Erasmus has said. It can be caused by malaria, anything. So anything which can give you a dysregulated host response to an infection can give you sepsis. So we just need to have a high index of suspicion, and then we shall manage our patients well. And then also, many times we have been seeing patients who have sepsis, they have septic shock, and they are managed on the don't know what. Let's know when to refer. Any patient who has sepsis, ideally, they should be in an HDU setting. So, because according to the definition of sepsis, we no longer have the word severe sepsis. Right now, as long as it's sepsis, it's really severe, they have multi-organ dysfunction. So, such patients need an HDU setting and above. Thank you so much.
Okay, thank you very much to all our panelists. Now to everyone who has kept on this call till this very minute. Sorry, we had to shoot a bit, but every minute counts. And our last norm of EMS Echo is to take a video for whoever has been present. So shortly, we'd request everyone to turn your video on, and then we shall take our screenshots. Okay, you can see your one now. We're waiting for you. Okay, so yes, and that is taken. Yes, our shot is taken. And from the team here at SID Global and to everyone that has been part of this session, we want to say thank you so much for tuning in and for listening in. Your presence makes our presentation valuable. We are glad to be part of your educational journey in management and approach to emergencies in Uganda. Until next time, we'd love to say